All right. So, hello, everyone. Before we get started today, I just want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. My name is Autumn Sipis. I am the project manager for the Canadian Coalition for Green Healthcare. And on behalf of the coalition at CAPhE and Peach, I would like to welcome you all to today's webinar, Optimizing Medication Use, Strategies for Sustainable Healthcare. Throughout the event, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and our panelists will be answering questions at the end of the event today. We will also be recording this presentation, which will be sent to all registrants and will be available on our website and YouTube channel at a later time. And here's just a little diagram of where the Q&A and chat buttons are for your reference. I would now like to welcome Caitlin Roy, who will be hosting today's session and introducing our speakers. Caitlin is a clinical support pharmacist for the Saskatchewan Health Authority. She completed pharmacy at the University of Saskatchewan College of Pharmacy, the American College of Clinical Pharmacy's Research and Scholarship Academy, and a Master's of Science in Pharmacy from the University of Saskatchewan. Able to Regina Pharmacy Department's Environmental and Wellness Committee, as well as the Canadian Association of Pharmacists for the Environment. Take it away, Caitlin.
Thanks, Autumn. I'm excited to be here. I'm joining from Treaty 4 territory in the city of Regina, and I'm here representing the Canadian Association of Pharmacy for the Environment, or CAPhE. I encourage you to check out our website or us on social media. And I'm delighted to be introducing our speakers today. I've had the pleasure of meeting Erin and Elisa through discussions and learning about the incredible work that they're doing. So I'm excited for them to share that with you today. Elisa is a medication use evaluation pharmacist with Fraser Health. She is also a clinical assistant professor with the Faculty of Pharmaceutical Sciences at the University of British Columbia. She completed her Bachelor of Science in Pharmacy with UBC, a hospital pharmacy residency with Lower Mainland Pharmacy Services, and a PharmD with the University of Toronto. And we have Dr. Erin Tajani, who is a researcher, educator with the Therapeutics Initiative, clinical assistant professor with the Faculty of Pharmaceutical Sciences at the University of British Columbia, and medication use evaluation pharmacist with Lower Mainland Pharmacy Services in Vancouver, BC. He completed his Bachelor of Science in Pharmacy at UBC in Vancouver and Doctor of Pharmacy degree at Creighton University in Omaha, Nebraska. So I'll let them take it over.
Great. Thanks, Caitlin and Autumn. It's a wonderful invitation to present this webinar and for all the support you've given us to get ready. So I'll start and then Elisa will be taking over and then we'll be going back and forth with some of the slides. So I'll just share my screen and you should see this. And I'm going to give Elisa control too. So welcome. What Elisa and I wanted to talk to you about was the role pharmacy may play in identifying and looking for high impact, low effort interventions to promote sustainable use, reduce medication waste, and save money at the same time. And we've been very fortunate in our roles in medication use evaluation to have the freedom to explore some of these ideas. And this started about 7 years ago when Elisa noticed some interesting patterns with inhaler use, and we started talking about it and did some investigation, and she determined that we were wasting a lot of inhalers. And ever since then, we both have been working together to look back at some of the stuff we've been doing historically in our health authority, which involves 12 hospitals, and identifying issues around waste and sustainable or unsustainable medication use and trying to shift that more positively. So we'll start with some declarations. Let's make, so, our declaration slide is skipped. I'll just verbally tell you, I get paid by Fraser Health and I get paid by UBC. And for the last 22 years, I've stopped taking any money, gifts, enticements, or anything from the pharmaceutical industry. And in our slides, which I've shared with Autumn, is our email addresses so you can contact us. And Elisa has no conflicts of interest to declare either. So let's start with the analogy. Is this how we manage money at home? So imagine if you were like Homer and you had tons of cash in your bank account and lots of money in your pockets, and you were just flush with money. And then your family decided to use some of that money to go shopping, and you realized, well, you have lots of money left over, so you continue to buy supplies and buy more supplies than you need. And then you realize, well, you weren't really thinking about it when you bought all these groceries. And what you end up doing is ending up with a bunch of excess groceries and you just throw them away. Now, if you had a system like that in your home, it wouldn't be sustainable. And if you ended up looking back and thinking, I could have used that money I spent on a holiday, or my car broke down and I wish I had been more responsible with my money. I could have bought that new car that I need now. You would eventually look back at the way you were buying groceries and say, well, we need to change the way we handle things and in an effort to reduce waste and save money. But in a way, at least in Fraser Health, when Elisa and I looked back, we saw this kind of scenario playing out. And we noticed this and realized there's probably something we could do about it. And so this is where we think drug use evaluation pharmacists might fit in, which is saving money and reducing waste by improving how we manage existing medications and processes without adding more. So that right now there's a considerable amount of effort to look for new and exciting sustainable medication use products or processes, which is absolutely fine. And I think that work should continue in parallel to what we're proposing, which is you kind of also need to look back at the way you're doing things historically to see if there's opportunities for improvement. So what we'll do is we'll share a few examples of that kind of work that we've been involved in over the last few years, some of which is in the early stages where we have spent time trying to understand the problems before we jump to solutions. And some of the situations involve we've spent the time understanding the situation and the problems, quantifying how big the problem was, and then coming up with solutions, implementing them. And luckily, we've had some success. So I'll start with our general process about how we have approached things. So early in my career, what I thought was I was smart enough to see a problem, intuitively understand what the problem was, and my first instinct to what the solution would be the right one. So that's how I approach things. And over the course of several years, when I tried to solve problems with my first understanding of what the solution might be, it typically failed. And what I realized, and with some of Elisa's wisdom and patience to sort of calm me down, is that we should probably investigate and understand the problem first before we quickly jump into solutions. So this is how we do things now. Um, we we started with high volume, high cost, known to be bad medications or medication use processes. So you could probably, in your institutions, come up with a list of things where you know we spend a lot of money on these medications, we use a ton of these medications, and we suspect or know there's some inefficiencies in which we handle those sorts of situations. And then we categorize them by impact and effort. So the simple quadrant that involves one section that we're most interested in, which is high impact, low effort intervention. So then we categorized all the possible problems as low impact, high impact, or high effort, low effort. And then we focused on the high impact and low effort interventions to start with. And then we talked to people as one of our steps for trying to understand the problem. And we did that by observing workflows, and I'll explain or give you an example of what that looks like in just a second. So We had the pleasure of working with some wonderful pharmacy students and pharmacy residents along the way that we sent into different pharmacy operations or dispensaries and had them talk to staff, observe workflows, do time and motion studies, gather formal and informal feedback. And then we also did things like online surveys. And we basically just kept our eyes and ears open. And what I'll tell you at the end is that if you talk to nursing and pharmacy staff, they will tell you what the high impact, low effort interventions are. You just need to take the time to ask them. So here's an example of a recent project we finished where we had a pharmacy resident survey hospital nurses in the Lower Mainland, and we received over 1,000 responses from nurses in the Metro Vancouver area. And we're in the midst of analyzing results now, and Elisa's going to show you some of the preliminary findings from that. But we learned a great deal from just talking to nurses and hearing what they had to say. And then in terms of observing workflow, we had a student go in and basically follow the path of an inhaler from when it lands in the pharmacy dispensary and it's ordered, what path does it take through the hospital before it eventually gets to the patient in the hands of the nurse and potentially gets disposed of properly or improperly. And through this process mapping exercise, we identified several different areas where inhalers might go missing or are wasted or lost in the system. And we'll share some of those examples with you. So the point of this exercise is if you're interested in sustainable healthcare and you don't know where to start, talk to people, go through intuitively what you would understand as probably the areas that need improvement and look back at those processes and start identifying potential solutions. I think you're next, right, Elisa?
Yes, thanks, Erin. So I'm going to be going over a nursing survey that we did in our local area. And we wanted to hear back from any nurses that worked in healthcare facilities. Specifically, we were interested in their attitudes, their uh, experiences, as well as their recommendations concerning medication waste. And for the purpose of the survey, we considered medication waste as any inefficient use of medications, whether that be the disposal of multi-dose vials, any unused or surplus patient-specific medications, or any unused IV bags, as well as the practice of not returning any unused medications to inventory. So we heard back from over 1,000 nurses, and the majority of the nurses were hospital practice and had more than 10 years of experience, with the majority of nurses working in Vancouver Coastal Health. So from this survey, we asked nurses how concerned are they about medication waste and whether or not they were concerned. And from the responses, we found that 91% of nurses are concerned about waste. However, 73% of the nurses surveyed don't feel empowered to reduce medication waste. So why is that? So we asked nurses what barriers are there for reducing medication waste. And these are some of the highly mentioned barriers from the survey. So workload and a lack of time was a top barrier, as well as pharmacy practices. Many nurses responded saying that the dose volumes and sizes that are supplied by pharmacy exceeds the dose required by a patient, and hence there's wastage in partially used doses and partially used vials. Another barrier that nurses mentioned were process and system designs. So in some sites, there are no return processes in place. There's not even a return bin, as well as policy rigidity was seen as a barrier. And one policy that was mentioned quite frequently is the narcotic diversion policy. So examples that nurses brought up included situations where a patient requires a hydromorphone 0.5 milligram dose orally, and pharmacy supplies 1 milligram tablets. Due to the narcotic diversion policy, the half tablet that isn't given to the patient needs to be destroyed and wasted immediately to prevent diversion. Another barrier that nurses brought up was infection control and safety standards. Specifically, a policy that came up quite frequently was the insulin pen policy. So in our health authority, insulin pens cannot be shared amongst patients. So nurses share scenarios where a dose of insulin is used for a patient. For example, if they're on a sliding insulin scale, and only one dose is used for the entire stay, and the majority of the doses in that pen ends up being disposed of and wasted. Another barrier that nurses brought up was poor communication, specifically between pharmacy and nursing. So an example of this was a situation where preoperative antibiotics were sent to the ward that the patient was on previously, but now the patient is in OR. So that dose ended up being not used and wasted. So we also asked nurses what recommendations did they have for reducing medication waste. And the most frequently mentioned idea was to optimize dose sizes. So that means supplying smaller dose volumes or pack sizes to match the dose that the patient requires. As well, nurses mentioned that narcotics, insulin, and antibiotics were medications that frequently contribute to medication waste. Other mentioned ideas by nurses were having more clarity about what medication can be returned for reuse, having a better system for returning meds, and better communication between pharmacy and nursing. An example would be if an order is discontinued or the dose is changed, to notify pharmacy as soon as possible so pharmacy doesn't make up and send doses to the wards only for it to be wasted.
Great,
So that
thanks.
was the findings from our nursing survey. I'm going to move on now to a project that we did involving salbutamol MDIs in pulmonary function test clinics. So salbutamol MDIs don't have dose counters. So this creates a problem where we cannot determine how many doses are remaining in an inhaler when they're partially used. And this can lead to the risk of having inhalers being disposed of with doses remaining. So that means the inhaler is underused. As well, it can lead to overuse of an inhaler, whereby the inhaler is used more than the labeled number of doses. And by overusing an inhaler, such as using it beyond empty, it poses clinical issues for the patient, as well as diagnostic issues at pulmonary function test clinics. So salbutamol MDIs are used at pulmonary function test clinics to determine if a patient has asthma or whether or not a COPD patient is bronchodilator responsive. So using an empty inhaler could potentially lead to underdiagnoses of asthma or misclassification of patients. So in order to mitigate these issues, we turned to looking at weighing inhalers. So what do we mean by weighing inhalers? So in the literature, we found that there is a correlation between the weight of an inhaler and the doses remaining in an inhaler. So we decided to conduct our own experiment using the salbutamol brand of inhalers that is carried by our health authority. So we measured 5 salbutamol MDIs at 2 spray intervals and plotted the average weight of the inhaler by the number of doses remaining. And what we found was there is a linear relationship between the weight of the inhaler as well as the number of doses remaining. We also found during this experiment that if we spray the MDI after 200 doses has already been sprayed, a good mist still comes out. So relying on a mist being expelled from the inhaler isn't accurate. So what we did was we took the weights from our experiment and created a weight chart for RTs to use at the pulmonary function clinic. So before the RTs throw away an inhaler, they could weigh the inhaler and determine how many doses are left in it. And from then they can assess whether or not that inhaler could be used for another clinic day. You'll notice on the weight chart that we instruct RTs to discard the inhaler if there are less than 8 doses remaining. And that's to account for any variation in weights between different inhalers so that we don't have any inhalers being used beyond empty. So prior to implementing this weighing protocol at the pulmonary function clinic, we weighed 3 inhalers at the clinic. One of the inhalers was found to have 134 doses remaining at the time of disposal. Another inhaler that was ready to be disposed of had 0 doses, which is great. And then another inhaler, based on the weigh chart, it had negative 28 doses, meaning it was sprayed 28 times beyond empty, which is a problem. So what happened after we implemented the weighing protocol? So for 5 weeks after implementing the weighing protocol, we found that 14 inhalers were disposed of, and all 14 inhalers were disposed of optimally, meaning there were minimally remaining doses, as well as none of the inhalers were used beyond empty. Also, we found that a lot of the inhalers had extended use, meaning because the inhalers were being weighed at the predicted disposal date, they were actually found to contain more doses in the inhaler and hence used for additional clinic days. And one inhaler was even used for an additional 11 days at the clinic safely. So we found that implementing this weighing protocol prevented the overuse of inhalers as well as underuse of inhalers.
Great. Thanks, Lisa. So let's go on to the next topic, which is non-rescue inhalers in automatic dispensing cabinets. So if you're not familiar with hospital systems that use automatic dispensing cabinets in patient care areas or wards, they have what effectively looks like a vending machine, and pharmacy stocks those vending machines with different products that are likely to be used and ordered for patients on that particular ward. And the nursing staff goes and, based on the order, withdraws what they need from the dispensing cabinets. And what we noted was um, in many of our hospitals in Fraser Health, they had stocked these automatic dispensing cabinets with non-rescue inhalers, or inhalers that are used for the chronic management of respiratory conditions, products like Advair, Spiriva, or Brio. And the reason you put stuff in these cabinets or vending machines is so that the nurses have easy and quick access to the medications, but there's an unintended consequence. Because they're so easy to access, it can lead to waste, something that Elisa had documented in previous evaluations. So what ends up happening is nurses take out more than they need, or they take out one and that goes missing, so they take out another, and they can do that because it's readily available. But for these chronic medications, you don't need fast access. You can wait for the pharmacy to receive the order and send it up. So removing that fast access, we thought, might reduce the amount of waste. So we basically did an inventory of what's in all the cabinets in all of our hospitals, identified the hospitals that had non-rescue inhalers in them, spoke to 2 hospitals and said, hey, would you consider taking them out of the cabinets and sending them up from pharmacy only? And we'll monitor your inhaler use before and after removal and see if we can reduce waste. So we did that at 2 community hospitals. And in the course of 6 months, we saved 119 inhalers from being unnecessarily withdrawn and wasted. And that amounted to $4,500 saved at 2 sites within 6 months. So it's not a lot of money, but the number of doses that are contained in 119 inhalers, all of which would have been unnecessarily wasted, is substantial. And many of you already know the implications on the environment from inhaler waste and disposal. We also asked staff at the pharmacy dispensaries, did they get any reports from nursing that there were delays in getting the inhaler to the patient? So because they were coming from pharmacy, were there any logistical problems that we created? And they said, no, they didn't get any problems from nursing saying that they didn't get the inhalers on time. And the pharmacy staff did not report to management that they felt like there was a meaningful increase in workload by taking this on. So that's something that you might want to do incidentally, we noted in Vancouver Coastal Health, they do not have this problem. They were more careful about what inhalers or what multi-dose products go into the automatic dispensing cabinets. Okay, moving on to the next one. I think that's you, Lisa.
All right. Oh, I think
Oh,
it's yours.
this is me. Sorry. So medication redistribution. Uh, when COVID hit, everyone was concerned about bringing anything back that was on a patient care area back into pharmacy. And so we were talking about that during COVID and said, oh, that's unfortunate because we have so many meds that get sent up to patient care areas that are typically returned and put back into the inventory. And now because of COVID, that's all going to stop and they're all going to be wasted. But staff told us that we don't actually reuse a lot of that unused medication. So, which completely surprised us. And so we did a survey of all the hospital sites, and we found that most hospitals incinerate more than 50% of return meds most of the time. So these meds, if you can see in the top right of your screen, are unit dose packed. So each dose is sealed and labeled so that it's safe and you can be ensured of the integrity of the dose. But if that package is not damaged, that tablet or pill can be put back into the inventory if it was unused by the patient that it was originally intended to be used in. So um, what we realized is we were probably wasting tons and tons of medication and sending it to the incinerator. And so how big was the problem? We attempted to quantify this. And for, I think it was of the 21 hospitals in the lower mainland of Vancouver, we estimate that 500,000 doses are unused per year, most of which are incinerated, which amounts to about 1,200 doses per day for about $1,200 per day that's incinerated. So not only is it a waste of valuable healthcare dollars, it's bad for the environment. And the barriers that are reported by staff for why they don't collect these medications and put them back into the inventory is because they said it's not financially worth it. So if you spend 10 cents worth of labor to do that work for a 1 cent tablet, in their mind, that didn't make sense. And then pharmacy staff continue to get pulled to higher priority issues. So I'm going to use another analogy. Our contention is we're asking pharmacy techs to do the work, but we're probably asking the wrong people to do the job. So here's the analogy. I think pharmacy is doing their best and their technicians are focusing on more high priority issues. So imagine, unfortunately, your house catches on fire and the firemen arrive to the house and they're rushing in to put out the fire. And you stop the firemen and say, oh, by the way, when you're going out to extinguish the flames, can you go into my bedroom and there's a table by my bed. In the middle drawer is my will and my insurance papers. So can you stop what you're doing, go grab the papers and bring them out to me? I would suspect that the fire control staff would probably tell you that they have other things to worry about versus your paperwork. And what I think pharmacy technicians are doing is trying to get the right med to the right patient for the right reason as quick as possible. To ask them to step aside and return unused medications to inventory doesn't make sense. And we've tried this solution to identify staff at each hospital pharmacy site to do the returns for decades. And every time we try it, it always fails because they always get pulled to other priorities. So we came up with a solution. We thought that a nomadic agnostic pharmacy assistant program would be better. So what that means is you have regional pharmacy assistants that are not tied to any particular hospital pharmacy. They float around from site to site. And what they do is they go to each site and they focus on the medication returns and do all that work. So it liberates the site staff from doing the work and the site staff can focus on priorities. So we tested this system at 2 hospitals for 3 months. And if you account for all the labor and the expenses of that agnostic pharmacy assistant, the return on investment extrapolated to the 12 hospitals was you save $3.60 for every $1 you invest, for about $200 saved per hour, for a return on investment percentage of 363%. So basically, you have 2 people visit all the sites on a rotation. They process the returns, and the pharmacy staff don't have to worry about it. And we estimate that a program like this at our 12 hospitals would save about $800,000 after paying for labor. And that doesn't account all the indirect costs like rebuying, reshipping, reprocessing the medications that you have to buy again because you burned the supply you had yesterday. So it is financially worth it. And this type of program that we piloted didn't interfere with staff workload. I think yes, it's you.
Okay, so the last project we'd like to share with you is our dose rounding infliximab and rituximab project. It's currently in the works. So infliximab and rituximab are very expensive medications, and these medications are dosed by weight or body surface area. What we found in the literature was a 10% variance from the ordered dose is considered clinically acceptable. So what we're interested in is determining how many orders for infliximab or rituximab could be rounded to the nearest 10% and match, how many doses of infliximab or rituximab could be rounded to the nearest 100 milligram vial and still stay within a 10% variance. And this would prevent disposal of partially used vials and potentially use of more vials when a vial could have been rounded or when a dose could have been rounded down. So what we found so far, and these are preliminary findings, is that 1 out of 5 doses that were ordered for infliximab or rituximab could have been rounded down, but wasn't rounded down. And hence money was wasted by opening up an extra vial. We also found that 1 in 5 doses are not rounded up when they could have been. And this led to the disposal of partially used vials, which could lead to medication waste as well as environmental damage. So from the preliminary findings so far, 40% of the doses for infliximab and rituximab in our health authority could have been rounded and stayed within 10%, but they weren't. So our goal, oh, whoops, sorry here. Let me just go back.
Oh, I think you just have to click forward.
Let me just click this.
Yeah.
There we go. Okay, so anyway, so our goal is to implement an automatic dose rounding policy so that where the variance is still within 10%, doses that are ordered based on milligram or body surface area would be rounded to the nearest 100 milligram vial strength. And so I'll turn it back to Erin.
Great. Thanks, Elisa. So this is where we think pharmacy can help. Is in addition to, like I said, looking for new products that are a bit more sustainable, or developing new systems for sustainable medication use, it's probably a good idea to look back and see what you've been historically doing to see if there's inefficiencies and clean all that up as well. And what we found is there are lots of historical problems that can be cleaned up. For example, the medication returns, or for example, the narcotic diversion policies. So one of the things to focus on is we may have systems and processes in place historically that were done for a particular reason, but they have negative unintended consequences for the environment, narcotic diversion being one of them. And so if you look back with a creative set of eyes, there may be a solution to keep the same benefits of, say, the narcotic diversion policies, but also minimize waste. So add that sustainable lens to it. And for the medication returns, just thinking creatively about what solutions have been tried and failed over many decades, and are there other ways to do it now that you have a fresh set of sustainable eyes to look at it. And so taking the time to look back and get ideas from staff is probably a really really good use of time, and it's been successful for us. So, and our greatest success is just keeping our eyes and ears open and talking to nursing and pharmacy staff, and they know exactly where the problems are. And then you just need to make a list of those problems and then start to categorize them as high impact, low effort as a place to start. So that's all we had to share. We're happy to answer any questions or comments or provide additional information if you'd like.
Thank you so much, Erin and Elisa. That was really interesting to hear all the work that you're doing. I particularly like the Simpsons references. So, and I also appreciate you sharing the strategic approach you have from beginning to end in identifying the projects and carry through to, assessing and implementing. We do have a few questions in the chat, so I can read these out loud, and then between the two of you, you can decide who will answer. So while sustainable, reducing the wastage of medicines goes against the profit-driven model of the pharmaceutical industry. How can industry stakeholders' concerns be mitigated? Can it be argued that a sustainability-focused approach will be profitable in the long term?
It's a good question. I mean, in terms of, we didn't focus on that. That wasn't our priority. But I would suspect if you step back really far back and look at society and the planet as a whole, that sustainable use of resources, healthcare resources, whether it's waste reduction or just saving cash, helps everyone in the long run. So I don't know, Elisa, if you have any other comments about that, but I mean, it's pretty easy to make the argument that if we're careful with what we use now, and don't waste unnecessarily, that money can be used for other things like innovation for the pharmaceutical industry, or we would have money to buy other products that could be used in other areas. So I think it's a pretty easy argument to make.
So from being able to reuse medications, like returning medications to inventory, I don't think that hurts industry directly, as these are medications that we've purchased. We want to use what we've purchased. So in that sense, I don't think it affects the industry's perspective since we're using what they've made. Other areas that perhaps industry could work on, if they want to be sustainable, is smaller dose packaging would be helpful for us if there are any industry callers here, so that we can supply smaller dose sizes to the wards and minimize the impact on the environment.
Great.
As well, if there are any industry people here, if you could put dose counters on inhalers, that would be much appreciated too.
Absolutely, I second that. Okay, next question. Hi, from the Netherlands. We have the dose rounding integrated in our computer system. In my hospital, pharmacists are allowed to click yes for plus or minus 10% rounding on all chemo and immunotherapies. Is this also common in Canada?
It's not common in our area. And it's surprising. Like when Elisa and I read the literature that's out there, we thought, oh, this is so obvious. And I wish we would have known this. So I don't know about other parts of BC or Canada, but it's certainly something now with computer physician order entry and some of the technology, that these automatic interchange policies, not just for the monoclonal antibodies, but like you said, chemotherapy. Other people have been doing it for a long time, so we need to start.
What we found was, in Lower Mainland Pharmacy Services, there's also Vancouver Coastal Health within it. And what we found was, for when we were doing the infliximab rituximab project, doses are rounded to the nearest 10 milligrams. But if you round to the nearest 10 milligrams, it doesn't actually match the vial size always. So perhaps something to consider is how the dose is rounded in the computer system as well, in order to match dose sizes available. And that may help with environmental impact as well as savings on financial savings as well.
Thank you. Yeah, that's a really interesting concept, and I think something that could be further explored across Canada in the different systems. And, the dose rounding policy, not only to make the measurement easier, but also in the concept of the vial size. I really like that consideration. And also, like, just to share perspectives too, computerized prescriber order entry presents a large opportunity for this type of practice. But unfortunately, some systems, are still paper-based, and then in those situations will require different systems, maybe even an order set to implement the rounding policy.
Yeah, that's a good point, Caitlin. And we also thought, like, if you're trying to sell this concept to your leadership, one other thing would be a dose rounding policy would also make the workflow way more efficient. And there's a potential to reduce medication preparation errors. So there are a number of positive unintended consequences
Yeah,
to a dose rounding policy.
Okay. Was it difficult to create the business case prior to seeing the savings for the returns pilot using pharmacy assistants? Also, is your technician workforce unionized? And if so, how did you manage assistants being added to the group for a task normally given to technicians?
So it was relatively easy to do the business case. For example, there's standards for how much mileage you pay these nomadic agnostic assistants to drive around. So that's easy to calculate the distances with the internet and Google Maps, no problem. They are unionized, and so there's schedules about exactly how much they get paid, exactly what the benefits are. So overall, it's just Elisa's attention to detail with doing the math, not hard. There was no resistance. Right now in BC, at least, we have a regulated pharmacy technician shortage, but there are lots of assistants around to be hired. And I didn't hear any resistance from any technicians or staff about why are you farming this task off to assistants now? So Elisa, did you hear anything about that?
No, I think for us, because there is a pharmacy tech shortage, people are open to the idea of using pharmacy assistants in any areas that would be uh, regulatory acceptable. And to answer your question, yes, our technicians are unionized in BC. Another thing with doing the pilot, prior to doing the pilot case, we also tried to assess the value of the medications that were being discarded by using our own volunteers from students in order to help build the case, in order to have the pilot initiated. And then from there on, we had the pilot, which showed savings, and then we made our business case.
The one hitch we have in Fraser Health is that the medication budget is owned by the clinical area, not the pharmacy. So medicine, emergency surgery pays for the drugs that are used in their areas. But if pharmacy spends the resources to return the meds and they don't see the benefit in their budget, there's an issue. So we're just working with the health authority leadership to get the clinical areas to contribute to the nomadic assistance because they will see the return on investment. So there's some financial logistics to goof around with, but
That's interesting when you get into the details of it. Complex systems all coming from the same budget, but then as you break it down, how that's further deviated makes a difference.
That's right. And then the other issue is if you get a tech or two at a site doing the returns, it's incredibly boring work. And so the roving pharmacy assistants, it's still boring work, but at least they're going to different locations and their work environment changes. So it adds a little bit of variety to not make them want to quit, hopefully.
Yeah, that's a good point too. Just to follow up with that, when you were investigating this pilot, did you see what else is occurring across Canada? Do you know if other sites have implemented a specific position for this work?
We don't know that, but we published a survey of Canadian hospital pharmacies. I can share the link with you in Autumn. And we asked similar questions like, do you know if you return all the unused medications? How often? Which meds do you return? Which meds do you don't? Which meds don't you return? And uh, there's a range of responses, but what we found is that not everyone is returning most of the meds most of the time across the country. So these problems likely exist all over Canada to different degrees. And um, so there's an opportunity to spread this idea further. But I would suggest that if you work in a hospital system and you don't know what's going on with your medication returns, you ask. And then the solution might be different depending on the context in your area. So this nomadic plan for us seems to work because we're geographically quite spread out, but it might not be necessary for a smaller area. So that's one thing to consider. And one other um, tip I can give you is, for example, we asked one small community hospital pharmacy, do you want to participate in our pilot? And they said, no, we don't think we collect a lot of returns. We wouldn't be a good site for your pilot study. They were convinced that they don't see a lot of returns. And we said, well, are you sure? And then the more questions we asked, we realized what was happening was the nurses were disposing of the meds, so the pharmacy never saw them. It was all happening outside of pharmacy. And so we said, would you mind telling the nurses to send it all down to pharmacy first? You make the pile and then show us the pile, and we'll tell you if that's a big enough volume. And they were surprised when they did that. Within a couple of weeks, they had bags and bags of meds that were sent that were destined for the incinerator that they had previously not set eyes on. So they realized that, oh, we actually do have a lot of returns. And so even if people tell you there isn't a problem at a hospital site, keep on asking politely and diplomatically. But I suspect there probably are problems that they don't realize are happening.
Very good point, Karen. Another related question to the unused medications. How is unused medication collected from hospitals? Is there a specific container designated for safely collecting these medications in each unit?
Yeah, Elisa, do you want to describe the Daniels process?
Yeah, so for, um, I think I read the question as for medications that are returned to pharmacy, I believe. So there are bins that are kept in the medication room. So these are the rooms where our Omnicells or Pyxis machines are located. And so nursing can put back medications into those bins, which are then returned to pharmacy. The one thing we ask is that if the medication entered a patient's room that was under precautions, that those medications are not returned to pharmacy. We don't reuse those types of medications.
And so those returns bins, they come back to pharmacy and then they're potentially able to be put back into inventory. We checked with infection control about do those packages need to be wiped or anything like that? And they say no. As long as they don't come from a room that was precautions, or if they go into the patient room and then come back out, that's off limits. But most medications, the bulk of them are stored in the med rooms, and then the nurses take the dose and they walk that into the room. But the threshold for return or not return is that the doorway to the patient's room.
Thanks for sharing. That's all for the Q&A in the chat box. So I encourage everybody to put more questions if they do have. We have still about 9-10 minutes. I have a question myself, though. So a lot of the work that you're describing, I'm impressed to see the engagement of nursing, pharmacy assistants, technicians, and, other disciplines within the hospital. I'm wondering if you can speak to, the importance, the value of the interdisciplinary team in moving this work along, as well as, challenges that you've maybe overcome to, get that buy-in from the other partner to do that type of work, for nursing to start putting medications into a bin, or the change in their workflow?
Yeah, it's a good question, Caitlin. So the interdisciplinary aspect of this is critical. Pharmacy is only one player in the life or the path of a medication through a hospital system. Infection control would be really important to talk to your infection control professionals to talk about the safe movement or reuse of medications or disposal. Respiratory therapists, nursing, pharmacy. We see a lot of medication loss when patients are moved through from emergency to a ward, or ward to ward, or ward to surgical unit, and then back to the ward. Things go missing. So the porters, the unit clerks, there's so many people involved. Pharmacy leadership, health authority leadership. Getting them all involved is important. And for me, the most interesting part of it is because everyone sees things differently from their perspective. So you get a really good insight into what the problem is and what the solutions would be if you ask people outside of your own little world. Surprisingly, it has not been difficult to get people engaged. I mean, the technical aspects of full-scale implementation, bureaucracy moves slowly for those sorts of things. But if you ask around, like, who's interested in reducing waste, everyone seems interested. So right now it's on the minds of a lot of people, and they're willing to help. And if you don't, you might not get everyone saying, yep, sign me up to be a part of the pilot, but you will easily find one or two places where people will say, I'm happy to test out your idea. And I think that strategy works well because if you can show success in a small pilot and it's easier to spread after you've already shown it works. Or you do something in a small scale pilot and you realize, oh, we didn't get our idea right. And so you learn from that and tweak it and then do another pilot. You know, the PDSA cycles and all of that plays out so nicely when you start with small scale implementations. Elisa, you've had a lot of interaction with the RT specifically. What do you have any
Yeah, so
comments on that?
when we were trying to implement the weighing protocol at the pulmonary function lab, the RTs, the respiratory therapists, were actually very excited about the weighing protocol because previously they were just going on like the feel of the medication, whether a mist was coming out. So there were some moral concerns about whether or not the inhaler was actually empty or if it had doses remaining. So they were very interested in the weighing protocol. And all of the RTs were also interested in environmental stewardship as well. So it was very easy for us to implement this weighing protocol there.
In one more thought about your question, Caitlin, is what's worked well for us is two things. One is if your organizational strategic plan has specific things related to environment or sustainable use or reducing wasting money, but even if it's indirectly related, then be creative and find a way to take your pet environmental or sustainable medication use project and somehow fit into a strategic goal of the organization. And then leadership starts to listen because they get something out of it too. And then the other thing is most of these projects, Elisa was just saying yesterday, reducing waste is saving money. It just sort of happens. So make sure you include metrics in your evaluation plan that also talk about other things that people are interested in. And one of the big ones is money. So if there's financial savings to be had, then why would they say no? How can they say no?
Great point, Erin. I really like how you're phrasing your projects, cost, workflow, and the environment. It's not necessarily only the environment, which might, not be everybody's cup of tea, but instead having this multi-purpose for the various projects. And I also like the idea of just asking, just starting that discussion, maybe leaving your office and having those conversations.
Mhm.
I do have one more small question, then I think we'll be ready to wrap it up.
Mhm.
You know, when meeting with you and first talking with you, it was an aha moment for me that drug use evaluation pharmacists are in the perfect position to like kind of have this perspective of the healthcare system. And, you know, within your workflow, you're already identifying these high used, high cost, you know, different opportunities for reducing waste. And so for those on the call who maybe aren't in that position, what would be some strategies to engage, you know, and continue this type of work in their own systems?
I think two things that I just mentioned actually. Um, so it took a little bit of convincing even for us to say this is part of medication use management or drug use evaluation. And so it's just being creative and getting people to think differently. You know, sometimes you get put in these historical traditional roles and then you just need to push the boundaries a little bit. So if you do a little pilot that shows money is saved and there's some environmental benefits, then that makes people pay attention. And I don't know, just being strategic about finding projects that meet the needs of your bosses that didn't come from I want you to save money or help the environment, but adding those elements to it, being a bit sneaky.
The other aspect, that one approach would also be if it's a medication that is on back order, that
Mhm.
would be a great opportunity to try to reduce wastage of that medication and to perhaps change processes in order to conserve that type of drug. And
Mhm.
that would affect every clinical area. Every clinical area gets hit by drug shortages.
Mhm. Yeah, good point.
Great thoughts. Thank you for sharing that and for presenting today on the important work that you're doing in BC that we can all learn from across Canada. I think that will wrap up the webinar for today. Just a reminder that the webinar is recorded, will be posted on YouTube, and will be emailed out to those who had registered as well.
Great.
Autumn?
Perfect. Yeah. Thank you so much, Caitlin. Thank you, Erin. Thank you, Lisa. This was fantastic and perfect timing, 9:59.
Good.
All right. Thank you, everyone who joined us today. Take care, everyone.
Have a good day. Bye.
Thank you.